và gia đình.
We have to move on because schedule is very tight. So we move to the next session of this morning in the main arena, the STEMI and acute coronary syndrome. So the co-chair of this session is Professor Eric Eckhout from Switzerland. We have distinguished panelists here, Professor Brian Yan from Hong Kong, Dr. Yong Kyung Kim, Korea, our friends Dr. Rajinikan Rajagopan from Brunei, Professor Nguyen Văn Thưởng from Khánh Hòa, Dr. Vũ Hoàng Vũ, UMC, Ho Chi Minh City, and Dr. Đỗ Văn Chiến is 108 Military Hospital. So to start, Eric, please introduce the first speaker.
Yes, thank you. The microphone has been fixed. So it's a pleasure to introduce Dr. Quang from Hanoi. We don't need to introduce Quang. Everybody knows him. He's now one of the prominent figures in the Vietnam Heart Association that will organize his national meeting next week in Hue. Quang, the floor is yours.
Yeah, thank you for your kind introduction. First of all, I would like to thank the organizing committee to ask me to share this topic. And my topic today is we just seeing how we can do differently with the plaque erosion in the acute coronary syndrome, including the STEMI. So I have no conflict of interest. So basically, this is a diagram showing that the thrombosis in the coronary artery disease involved very much for the progression of the plaque. And you can see here, there is some way progression of the plaque in the coronary. Somehow it can be like erosion, somehow it can rupture, or it can like a calcified noodle. Every pathway come into the thrombus, and we have a coronary syndrome. However, recently, due to the apply widely of the OCT, we have more data involving the plaque erosion. And if you try to identify the prevalence of the plaque erosion, you can see here the data from a lot of studies showing the prevalence around more than 30%. So basically, 30% of the case you got in the cath lab is due to the plaque erosion. And if you compare two groups, one is the group is the plaque erosion versus rupture, you can see the patient with the plaque erosion is younger. Usually it is a non-STEMI setting, absent of the traditional risk factor like diabetes or hypertension or chronic kidney disease, and also the lower level of the inflammation. So this is something like for you to have some overview about this type of the plaque. And you can see here, this is some data showing that this is for the non-STEMI population. And if you have more than 4 criteria like that, young patient, no diabetes, hemoglobin more than 15, and normal renal function, and more than 70%, you got a plaque eruption. So this is something like you can predict the subtitle of the plaque when based on the clinical evaluation. However, if you come further, if you compare the plaque burden between the two groups, erosion versus rupture, you can see in the group with the rupture, the plaque burden is more than that. Due to the whole system, like the whole coronary, got the inflammation and also got a plaque. And if you go further a little bit, like how it can happen, what is the pathology, biology of the plaque erosion, you can see here the one picture showing that all the plaque eruption involved into the endothelium denudation. And the other part, the plaque rupture involved in the inflammation. And if you go a little bit further, you can see in the diagram showing that usually the plaque erosion involved in the concentric, the plaque, whether the rupture plaque involving the eccentric plaque. So this is some way how you can see what was different between the way you can create the plaque rupture or erosion. So the next question is how to identify the plaque erosion. So it is a criteria and algorithm based on the OCT. when you do the OCT, based on the, how you can see the fibrous cap is a rupture or not. And if you say something like intact fibrous cap, and then you see how you have a intact underlying plaque visualized, and if everything is visualized, it means that it is definite the plaque erosion. The other part, you need to exclude the calcification, exclude the thrombus, and then probably the plaque erosion. And usually, you only can use OCT to identify this one. The IVERT, you can identify the rupture or thrombus, but not easy for you, for the IVERT, to see the intact plaque visualized. So that's why OCT is the main thing to consider. So is there any difference in terms of outcome of the plaque rupture or erosion? And you can see here, this is the data showing that for the plaque erosion, the thrombus burden is less. And that's why when you put in the stent, the thrombus, the approaches inside the stent is low. And also the distal embolization also is very low in the group with the plaque erosion. However, this is one study showing that the plaque erosion can delay the vascular healing after you putting the DS in the acute coronary syndrome setting. It might be due to actually the thrombus can extract the growth factor, and this one can help you the vascular healing better. So this is something you consider. The plaque erosion can have some worse outcome and need to different way to check it. So the next question is there any difference between when you treated the erosion, plaque, and the rupture? Usually for the ACS, you go to the primary PCI, you put a stent. But however, there is a few studies showing that in the plaque erosion, you can treat it without a stent. So this is a very important study. Even this is an observation study, it's erosion, showing that for the plaque eruption, you still can treat it without stent and only with the antithrombotic therapy. You can see here after 1 month antithrombotic therapy, more than 78% already reduce the burden of the thrombus, and nearly 40% patients have no thrombus anymore. So this is a very promising area when you can treat it without a stent. And is it safe or not? So actually, when you put a stent, when you put a DS for the patient with the acute coronary syndrome, you still got something like a 2% per year. So this is a study showing that the stent is not benign. So if you can avoid the stent in any situation, it's really good for the patient. And also the data showing that for the primary PCI, for the STEMI, drug-coating balloon is also okay. So in reality, showing that even for the acute setting, you still can treat the patient without the stent. So if you go further into this group, and you can see that the response to the antithrombotic at 1 month is crucial. So this is the data from also the erosion study, divided into the 2 groups. One group, the blue one is very less thrombus burden after 1 month. And the red one is the big thrombus burden at 1 month. And you can see that if the patient did not respond to the antithrombotic at 1 month, then the outcome is less. And also patient need to do the stent later on. So this is something like you keep in mind. If you don't put the stent for the patient, you need to very powerful antithrombotic therapy for the patient. So this is something like after the erosion study, they proposed the algorithm for this type of the lesion. Based on the STEMI or non-STEMI situation, if the STEMI, you shut on the thrombus, you do the OCT. If it is a plaque erosion, you just stop and putting the antithrombotic therapy. And if it is a non-STEMI, non-ST elevation acute setting syndrome, then you can predict where is by the clinical evaluation, and after that you check again by OCT and you divide it. So this is some way the algorithm based on the morphology of the plaque. However, the question is, in reality, in reality, after 4 years, still got more than one-fourth of the patient need to do something. So it is not benign. And the question is how to identify the group. You really need to PCI after you putting nothing there. So this is a study showing that if you calculate the burden of the plaque erosion, and it is the criteria. You can see here if the patient is older, more than 60, and also the thrombus burden more than 20%. If the plaque burden is more than 60%, then the patient need to stent later on. So that's why based on these criteria, you can identify what kind of patient in the future, not in the first year, within the second year, the third year, you still need a stent, and at this point you can put a stent for that. And another important way is you try to identify the lipid content for around the erosion side. So here the data showing that this is OCT, and you can identify the proximal external erosion near the erosion site. And if the high burden of the lipid content at this point, then in the future, patient need to do the stent again. So this is a way how to identify the group cannot using the without the stent strategy for the patient. So based on this one, you can consider like for the future, you can use the high tech, for example, like this is a data showing that you still can use the AI-based model to diagnostic the coronary plaque erosion. And in this situation, you can identify what type the lesion is not suitable for the not putting a stent, and what kind of the lesion is suitable with the anti-thrombotic therapy only. So this is the future, and when you can predict the plaque erosion based on the AI. And another frontier for that is you try to combine the IVERS OCT together, or you can try to combine OCT with the NIR. And this situation, you can identify the molecular background for the plaque, and then you can predict for the future. So this is something like a very promising, but however, so far, until now, I can got some summarize. The plaque erosion is account more than 30% of the case of the acute coronary syndrome. And so far, the available evidence suggests that in the patient with ACS with the plaque erosion, you still can use the very powerful anti-thrombotic therapy without stent, and the future is okay for the patient. And actually, the future research should address into the 2 points. The first one is how to identify the subgroup is not suitable for that, even if it is a plaque erosion. And the second one is a new therapy strategy target to the molecule pathway involved in the plaque erosion. So this is something for the future. And so far, I have only few things to say at this moment. And thank you for your attention.
Thank you very much, Quang. So I look at Jack, and then I think the future is bright. Huh? When you discussed before the PREVENT trial, I think we're going to a great future. Any comments and questions from the panelists or from the?
Yeah. So thank you, Professor Quang, for very comprehensive presentation. So because we have to classify the erosion or rupture by the intravascular imaging, especially for the OCT. So if I don't have the OCT, so what we can do in daily practice when we think about the erosion and rupture? Yeah.
So I think in reality there is a few things we need to do in daily practice. First of all, for the older case with the thrombus, we need to suck the thrombus. Not only to reduce the distal embolization, to reduce the number of the stent, but also to give you a chance to identify the plaque rupture or not. The second one is if we don't have the OCT or the IVERT is not very clear, then you can predict a little bit based on the clinical variable. So we can see like the patient got a non-STEMI, young patient, not very high risk of the cardiovascular traditional risk factor, then the chance of the plaque erosion is very high. So in this situation, if the lesion is not very critical, and I still can leave alone, give a lot of anti-thrombotic powerful, and then still wait for a while. And if you still considering, then you put the patient back again after a few days and do the angio again.
Also to already enter into the next discussion, the next talk, you know, the eruptive calcified nodule now is also a new concept that we learn from OCT. Any comment on that?
I think the calcification is another story and really interesting, because in reality we don't know how connecting between the plaque erosion, plaque rupture, and calcinutor. I think all of them is the different aspect of the plaque, and it depends on the clinical setting, and then it become in different way. For the plaque rupture and plaque erosion, it might not be put for the plaque erosion, it might not need to put a stent, and also similar for the calcified noodle, because if you put a stent, you might have like an unexpanded stent. So in this situation, if you have a really good intravascular imaging, you can decide it, and you no need to put a stent for this kind of the lesion. And we wait for the next speaker to see and how.
Kwang, great talk. Learned a lot from that. And you mentioned DCBs along the way, the possibilities of DCBs in the erosion. And that's an idea that's been proposed. And Bruno Scherer wrote an article last year suggesting that in borderline lesions with erosion, you could use DCB. How do you decide? I mean, just because it's, there is antithrombotic therapy, and there is stent which we can avoid. In which cases would you choose to do DCB? Is it based on lumen size? How do you make the decision?
I think that the one data is really important, showing that the plaque burden outside the erosion site is determined for the future. So it is really important to measure the outside. So if you have an IVUS, you can calculate the burden plaque outside the erosion site, and if it is really huge, then you put the DCB. And if it is not, then do nothing, just antithrombotic therapy, because the plaque erosion is still okay.
So you would use imaging rather than physiology? That's a significance.
Yes,
excellent.
I think so.
Thanks.
Yeah.
Dr. Well, because it's difficult for IVUS for nose BE. So you think with IVUS with clinical symptom, you think that this is BE. So you don't use stent. So you use Plaque, etc. But I think you call the patient come back after 1 month, 3 months to check IVUS, check angiography or not.
No, I don't think so. The main thing here is the data from the erosion study showing that for the plaque erosion, you can do nothing. So if you really want to put a stent, you need to optimize the result of the stent. The stent should be perfect before the patient leaves the cath lab, because in reality, without the stents, patient is still okay. So if you don't know is it the really plaque erosion or not, you need to put a stent. Then you should optimize everything perfectly before patient leave the cath lab.
Yeah. Just my comment is that we have to know that it is very, very difficult to distinguish between the plaque erosion and the plaque rupture during the especially primary PCI. So what can I imply the erosion trial? So during the primary PCI, after thrombus aspiration with loading of the P12, it is prasugrel 60 milligram and GP2B3 inhibitor. And angiography showed the stable but remaining the stenosis, but patient really safe. At that time is sometime if we put the stent, there is a stent is the resource of the thrombus. That time is we have to take a rest and move to the patient to the ICU, and as you mentioned before, it's a very potent antithrombotic thrombosis. And a couple of days later, is a follow-up angiography show the decreased thrombus. Yeah, that time is we would defer the stent implantation, but there is also remaining is a huge burden of the thrombus. That time is time to put the stent.
Yeah, one more comment is about this one. To the guideline, we know that thrombus aspiration is contraindicated. But in your talk, in order to differentiate between the erosion and ruptures, we must aspirate the thrombus in order to see the surface of the plaque. So, do you think that in the future we can change the guidelines that maybe the routine aspiration for specific categories of patients?
No, I don't think so, because in the guideline only showing that the routine aspiration is contraindication. In the case you need to do, you just do it. So it is a not contraindication if you have a huge thrombus burden. So I don't think the guideline is changed. The thing changed here is you should to consider a little bit before you put the stent. So this is the main thing.
So
It's true, but we have to. But now in Europe, a lot of people don't want to aspirate anymore. They say guideline, no aspiration. They don't aspirate. You know, like this. Sorry, we have to go on. I think.
Okay. Thank you. Thank you.
Okay, thank you, Quang. You want to introduce the next speaker?
Yeah.
Oui.
Okay. So thank you very much. We have a beautiful discussion. So because of time, we need to move on. So I would like to call Dr. Takashi Kajiya from Tenyuki Central Hospital in Japan. Have the next topic, how to treat calcified lesions in STEMI patients.
Thank you very much, Dr. Hui, and I thank you for the organizing committee for invitation. So today my topic is how to treat calcified lesion in STEMI. So before the starting talk, let me introduce myself first. So my hospital is located south part of Kyushu, and located in the center of the city. And so as you can see, there's a beautiful mountain here. And this view is from our rehab center, so patients can enjoy this beautiful scenery during exercise. However, the problem is this mountain is an active volcano. So roughly once a day, this mountain has an eruption. So from my city, Kagoshima, to here, I took a flight from Kagoshima to Tokyo, 1.5 hours, then another flight to Ho Chi Minh City, 5-hour flights. So next time you can come to Kagoshima the other way. So the geographic feature of Kagoshima is very unique. We have 28 islands with people live. And from north to south, 600 kilometers. From Kagoshima to Kyoto, around about 600 kilometers, so it's a huge prefecture. So we have so many islands. So most of the islands, they don't have cast off, so we use a helicopter, we call the doctor helicopter, and patients come to my hospital around 40 to 5 cases in a year. And most of them, our centers, PCI number is 600 around the years and 250 peripheral cases in a year. And 20 to 30% are ACS. So the last year, ESC updated the ACS guideline, but it is the European guideline. So from Asian perspective, we wrote just one publication. Still in Asia, we have some problem, so we need to do something more for ACS. So what is this? Is a calcification. So one case here, the 65 years old gentleman, undergoes STEMI. So luckily his LV function is still preserved. But as you can see, the angiogram, the proximal LD was completely blocked, and I did thrombectomy, I'm sorry. So after the thrombectomy, we could see the culprit region here. It looks simple. However, not the culprit region, just distal to culprit, this region was very tight. We used urvalin up to 20 atmosphere, then still we can see an indentation. Then we switched to the NSE, it's a scoring balloon. It's a high pressure scoring balloon, so we up to 27 ATM, but still we can see indentation. So this is IVUS. You can see a concentric, heavily calcified region here. It is just a short segment, not long, but it's heavy. We cannot see the thickness of calcium because we use the IVUS here, but still we couldn't open this. So what is the strategy for these lesions? Rotational atherectomy, orbital atherectomy, stage PCI, cabbage, or IVL. So if you choose a rotational atherectomy or orbital atherectomy, we have to concern on distal embolization or some complications. So this study is conducted in Europe, the rotational atherectomy in STEMI cases. This is not a randomized control study, but they compare the STEMI shock case and the STEMI non-shock case and the CCS. So the primary outcome here, I want to show this one. So in-hospital mortality in STEMI shock case is very, very high, which is 50%. Non-shock cases are 1.5, so it's okay. But if you use a lot of ablation in STEMI, we can say it's still challenging. So this is a procedural characteristics. Indication of root ablation is upfront root ablation about 20%, and the bailout root ablation is almost about 80%. So the most of the cases they use a root ablation for bailout. So they could get a TME3 flow, it's okay, but again, the in-hospital death was very high in rotational atherectomy in STEMI cases. So as you know, if we had a distal embolization in primary PCI, the long-term MACE is high. So for me, in this case, rotational atherectomy is kind of a risk. So, but state PCI after approval, maybe we have to take care of acute weak occlusion. CABG, just a single vessel disease? No. So the final choice is intravascular lithotripsy, IVL. So we use IVL here. Just 6 ATM, we could open up this tight lesion completely. This is a OCT image before IVL and post IVL. So as you can see, this angiogram shows no stenosis after IVL. So this is a comparison of before and after IVL. So as you know, if patient has a calcification, the clinical outcome is worse. And also in ACS cases, the culprit lesion has a coronary calcification, which is associated with worse clinical outcomes. However, we have so many calcium findings, deep calcium, superficial calcium, concentric, eccentric, and calcified nodule. So calcified nodule was a clinically significant underlying ACS cause associated with highest future major adverse cardiac event risks. So this is our data, which is still on submission. We compared calcified nodule cases and non-calcified nodule cases in hemodialysis patients. You can see the MACE and cardiovascular death and MI, all the hard endpoint was higher in calcified nodule groups. So calcified nodules, we need to still do something more. So before treating calcified regions, what we have to do is scoring using imaging like IVUS or OCT. So once we got a high score, you have to consider rotational atherectomy, IVL, or whatever. So the scoring is very important. And another point is, the severe complication we have to consider after using debarking devices. So this consensus document says it is necessary to prepare for complication during PCI for calcified lesions. So what we need to care is, the rupture, perforation, maybe a late tamponade, procedure MI, no or slow flow here. So we need to know how to prevent and how to manage after using a debarking device. So comparison of these lot ablation orbital and IVL, I want to point out here the procedure complications. As you can see, the IVL is the safest device for calcified regions. As you can see, the dissection rate is rare, the perforation is rare, and the no or slow flow is not reported. Sorry. So after scoring, we need to decide which debulking device or IVL is better for these patients. So that this case is a 63 years old gentleman in for STEMI. The mid RCA was completely blocked like this. And you can see some calcification here and also the left artery also. So we use just a normal balloon to open up this lesion. And as you can see that this guiding is kicking out and very difficult to close this lesion. So after balloon angioplasty, we did IVAS. You can see the concentric diffuse calcification here and nodule here. So we got TME3 flow after ballooning. And after this, this IVAS image showed a diffuse severe calcification with calcified nodule. So at this point, what we should do, if we choose the root ablation or orbital in this situation, maybe it's going to be trouble. So the point here is we stop the procedure here and put the patient to the ICU. Then around a week later, we did a staged PCI for this severely calcified lesion. We use a root ablation up to 2.0 millimeter. Then final CAG angiogram like this. So I showed the two cases. So one case we did something for calcification at the time of primary PCI. And the next case, we did debulking, not at the time of primary PCI. We did a stage PCI for these lesions. So debulking device is necessary for severely calcified lesions, and the selection of debulking or IVL is very important in ACS. And imaging devices like IVAS or OCT helps to decide the debulking strategy. Thank you very much for your attention.
Yeah, we are. Thank you so much for the pictures, the beautiful picture of the mountain. We are looking forward to visit Japan. It's a time to visit Japan. Yeah. Any questions? Calcium and yeah.
Good question. IVLs only works best with concentric calcification. What's your experience with more nodules and eccentric calcium with IVL?
Okay. For the concentric?
With nodules.
Okay, thank you very much. So the concentric calcification, yes, IVL is very, very, effective, but eccentric, some cases yes, but some cases no. So we don't know which eccentric calcification is indication for IVL. So most of the cases we try to use other like a debulking device, and also the calcified nodule is completely another concept. So we don't have any definite strategy to solve the calcified nodule. Still under going, I think.
It's true. Calcified nodule is really sometimes horrible. But is anybody in the room had a case of calcified nodule where you do your best, you still achieve something that is acceptable? It's very rare that you can do nothing. With the modern technology, you try your best, you combine technology, and you achieve something that is acceptable. I don't know what is the opinion, but you seem to be agreeing with me. That's kind of you. Any opinion?
I'm sorry. Do you use OBN, the high pressure, after IVL? What pressure do you use?
You mean after IVL,
yeah.
we use another high pressure balloon? Yeah, yes, I do. Most of the cases after IVL, we use a scoring balloon or like Urbalin to open up. So IVL, the high pressure balloon, then stenting is my strategy.
I saw that you use Wolverine up to high pressure, which
That's yeah. It's not
because I did it when I was younger, but now I don't do it anymore. But you do it still.
Yes.
Okay,
Yes.
okay. Any other opinion?
Yeah.
Because I'm scared. I've seen cases with blade problems, so that's why I don't do it anymore. Yeah.
No, Eric, I agree with your view that, I mean, calcium nodules are very difficult to treat, and I don't think we have the answer, but I do use IVL a fair bit, especially if it's non-eruptive, and it doesn't always work. But I feel that when there is a calcium nodule, it doesn't come alone. It comes with sort of calcium along the shoulders of the nodule as well, and there is quite severe calcification. And I think when we do IVL, we are treating not just the nodule, but also the sheet calcium on either sides of the nodule, and that maybe leads to a better result after stenting. So, I mean, the evidence, I think, is not clear for anything, and but I think it's useful trying IVL here.
Yeah. I think so. Then not only the spot regions, we have to think of the whole length of regions. The point that we need to do is IVL. Some point we need to use like a lot of ablation. Yes, that's right.
Okay, we have to go on. Thank you very much for
Thank you
your
very much.
nice lecture. Thank you, sir. Short one, very short one.
Okay, yeah, thank you very much for the presentation. Actually, the most important, I think, strategy is to open up when we have a ACS situation. So that's the last case, you open the flow, have a good flow, and you leave it and do it stage PCI. But sometimes for me, I don't have that much modern device, the bulky device like you. Usually I have used two small NC balloon, and then we can sometimes we crack it is quite good result, and we can put the stent in, or sometimes we just save the flow. This is my comment. Yeah.
Yeah, thank you.
Thank you so much. Indeed, we have good stuff, good material today to treat calcified lesions much better than before. The next lecture is by Dr. Ranga, and I really like the title because I see the word complications. So Dr. Ranga is going to speak about the prevention and management of primary PCI complications. Welcome.
Thank you, Professor Eckhout. I'm Dr. Asri Ranga from, okay, there's a podium here. I'm taller now. Okay, so my topic is prevention and management of primary PCI complications. I'm from Hospital Sedang, Malaysia, and no conflict of interest, just a bit of introduction. I'm from a public hospital, poor guy, and we do something like, last year we did 4,300 PCIs, more than 9,000 angiograms, we got 7 CAD labs, so we do have a lot of cases. So within 15 minutes to cover is quite a lot, so I have to actually choose the topics I want to. I'll be talking case-based, slow flow, and corneal perforation. I think all of you have seen, so it's more for discussion and so on. So I'll go straight to the case. A 78-year lady came in with inferior STEMI, ST elevation, so activated the primary PCI team, the left side, the minor disease, so occluded proximal RCA. So basically it was like, what do you call it, grade 5 thrombus, completely occluded. So the operator decided to wire and then daughter. So he saw that there's actually a long diffuse lesion. Maybe the tight one is at the mid RCA, ruptured plaque maybe in the proximal RCA. And we don't image all our cases. So usually they will pre-dilate, you know, there was flow after wire. If you wire an occluded artery, there's flow. Usually it's good prognosis. And there's some thrombus migration to PLV. So I think they decided to wire the PLV. Another they used a larger NC balloon, a trio balloon, and then acceptable, you know, pre-dilatation, and decided to stent a 3.5 36 des from mid RCA, and okay. So after that, what happened was no flow, no reflow. So we realized that most of the time in our STEMIs, it tends to be the RCA. When you have a lot of thrombus, ectatic vessels, it's quite common to see. It all depends what you do next. So the operator started the IV taurofiber and bolus, but what they decided is to go up even higher with the 3.5 NC balloon, which I think was not the right thing to do. Try to establish flow, come back, or try to, you know, do intravascular imaging. So obviously, it got even worse.
So then intracorneal adenosine times 2. There was some improvement in the flow in the RCA. I think, here the operator was pretty lucky. So we do come across this type of scenario, no flow. And I had cases where it's much worse. After all you do, you cannot establish flow. So in your mind, you must always think, is that dissection? Is it thrombus? Or is it spasm? And so here, the operator decided he wanted better flow. So he used actually, one of the things we do is actually try to use export catheter. Here, when you have no flow, slow flow, whatever the guidelines say, I think using an export aspiration catheter is very important. And that's why sometimes when we do, we need at least a minimum 6 French guide. If you've got 7 French, even better. So then you know that, angiogram-wise, so it was acceptable. So this is the final picture. So in this case, we're successful, but many a times we can be, fail when we do a slow flow, no flow, if you don't have a proper backup. One trick I learned along the way, especially not all centers have imaging, is actually, doing this. You can actually put your aspiration catheter distal and actually inject. When you do that, you can actually exclude, you can see it's actually true no flow. There's no dissection, no thrombus, it gives you a peace of mind. So you can do this, so this is a simple trick you can do. So going back to, no reflow is when you don't have, your TME flow is less than 2 or less, and this occurs despite the vessel being patent. But when you don't have imaging, it's very difficult. So you have to rule out dissection, spasm, of course distal microembolus. Although we use OCT most of the time in STEMI cases, but once you have no flow, you are stuck. OCT might not help you so much. You might need to actually use the IVERS and so on because it depends on the flow. So why you have no flows, we think it's actually the microvascular dysfunction. So it's more common, like what I mentioned just now, when you got large thrombus burden in diabetics and so on. When the patient presents much later, the thrombus is more harder, the EF is actually below 50%, and also ectatic vessels. Sometimes we do see this in patients with Kawasaki disease and so on. So the incidence actually differs, but most of the time it's more commoner in up to 7 to 10% of primary PCIs we do, and depends how aggressive we are. Sometimes when you have a lot of thrombus, like just now when you did the ROTA, the second case, very interesting, you do deferred PCI. You treat established TME3 flow, come back after a few days. Sometimes you realize the best treatment is actually TME flow. When you got TME3 flow, just with medication and so on, your GP2B3A inhibitors, actually the body will do your work for you. In here, if you go and try to stent it, you can cause actually more issues and so on. So why it happens? Well, people talk about distal embolization, there can be myocardial necrosis, cell edema, the cell gap, and also a lot of cytokine release, inflammatory markers and so on. So that can cause actually vasoconstriction. So sometimes you can actually end up when you want to do a perfect PCI, especially like just now the operator went to, NC with a high, NC balloon. Maybe you can do it later if you're worried. Bring back the patient after, 1 week or something like that once you establish flow. So this is again in a cartoon looking at the pathophysiology. Not all patients are the same, but when you see a lot of thrombus, always think of, you can have no flow phenomenon. And sometimes, I'll show you in the next case, sometimes complications always come not alone. They come, 2, 3, or 4 at a time, so you must know how to deal with it. So, of course, one thing we talk about is direct stenting, but that if you have a large lipidic plaque, I've gone away a lot from direct stenting, even in primary PCI setting, because I want to see what is distal and so on. And aspiration thrombectomy, whatever people say, but if you have a lot of thrombus, now when I see a lot of thrombus, I straight away actually give GP2B3 inhibitors. I do use a lot, up to 20-30% of my primary PCI, I do use GP2B. I have thyrophobin in my lab. Distal embolic protection devices, well, in coronary, it's a bit more lacking for the data and so on, unlike vein grafts, and we don't have like parachute device they have in Japan and things like that. Unless you got a big RCA, you can consider using your easy filter or something like that. Sometimes when you do that, you can actually push more stuff downstream. So most important, rule out dissection, spasm, and emboli, and also thrombus. But at the same time, we do have vasodilators available. None of them have shown to improve mortality in the long run. But the one to go to, usually in my lab, we use a lot of adenosine. Now we use a lot of also intracorneal adrenaline. And some people use isocate. Isocate does not really work. Nitrates don't really work in slow flow. So GP2B3 inhibitors are another thing I use. Of course, you have to actually weigh. Sometimes I get cases from other centers where failed thrombolysis, so the risk of bleeding can be much higher when you use together with GP2B3 inhibitors. There have been cases where I'm up against the wall. I've even used intracoronary thrombolysis, like metallized. And sometimes to support the patient, you might need security devices like IBP, Impella, and ECMO. So again, my strategy, assess the thrombus load after wire passing, early use of IVUS here because OCT might not work when you have no flow, and then thrombectomy in case of high thrombus load, and also try to limit contrast injections. Don't inject too much contrast. And do not go very high pressure with initial POBA. If you've got slow flow after POBA, consider deferred stenting. So I think that's also very important to consider when not to put a stent in. It's not easy. And if slow flow occurs, quickly go through your response with vasodilators, consider aspiration catheter, and you can actually deliver your medication through aspiration catheter, and also consider mechanical Elvis support in severe cases. So that's in a nutshell slow flow. Next, I will go quickly in the corneal perforation. Again, occluded proximal RCA. So if you can see, the operator actually wired into distal RCA. Looks very good. So RCA can be deceiving, okay? You think that the wire is in the RCA, and this happened more than once. So I will tell you what happened. No flow, okay? So they put a 2O balloon. 2O balloon, nicely done, you know? So this happens. So if Indians understand, I call this the ayoyo moment. We say ayoyo. So if the Indian says ayoyo, then you are in trouble. But this is one of the cases. I won't show you how it's done. I'll go to another more exciting case. So you must always be careful. Just because in your LA view, it looks like it's in the, the Y in the C, it can be in a different vessel. So this is another case. Anterior STEMI came in. So again, the operator saw the wire looks very nice. It looks like it's in the LED. Okay, so he was so confident, so he dotted, and he actually put a 2.5 to establish flow. You know, went up, mid proximal, nicely dotted, no problem. And then IOO happens. So actually the wire wasn't septal. You know, you thought it was in the LED, so it's a bad perforation. And then exactly what I tell you, whenever we have one complication, be prepared for second and third one. There were a lot more complications after that. So trying to wire into the true, LED, but at the same time, the most important thing you should do is actually POBA. While you are thinking what to do, put a balloon proximal, POBA. Don't go and POBA again at the septal. You know, so sometimes where you put the balloon is also very important. So they put a 2.5 balloon tamponade. Trying to wire into the true lumen was not easy. Here you can use a ping pong guide, but the operator decided to deflate the balloon, quickly wire into the true lumen. Again, here, the fastest thing is, I think they decided to put in a covered stand. So they put a LED, proximal LED across. They decided to sacrifice the septal, but at the same time, you can argue, you could actually try to put in fat embolism or coil down the septal. I think this was what was going in the operator's mind, but something happened after that. So what happened after that was they actually, they had difficulty wiring. They managed to wire down. They put a covered stand. But after the covered stand inflation, which was under, they lost all the wire. And subsequently, trying to wire the covered stand, it went abdominal wiring. They could not get anything down. But before that, they dilated proximally. And then the second complication happened, stent thrombosis. They did not reverse with protamine. With the covered stand, sorry, I cannot get the thing. Sorry. So always be careful. So the second thing happened was, so again, okay, you can see stent thrombosis. We didn't reverse the protamine, they put in the covered stand, immediately stent thrombosis happened. Another IOO moment now. So from perforation, now you again back into the same problem. So what happened was next, they lost the wire. We did not show that. Trying to wire down. So it took, like basically using field XDR, XDA, Gaia. And then after that, nothing, although the wire went in, balloons don't go in. So you use multiple, basically you're doing like a CTO now. You know, because I think what happened is the covered stent was underexpanded, you stop the bleeding, but now you have another issue, how to establish flow and so on. So I won't go through what happened, but you know, it was quite a nightmare, one complication after the other. But finally, we managed to use IVers, we managed to get everything down, there was flow, patient was much better. Of course, the septal was lost. So that's the thing about, you know, complications. So whenever complications come, always be prepared what is the next complication. They only call me when they could not wire down the covered stent. So again, coronary perforations are rare, less than 1%, but if they happen in primary PCI setting, it's much more, you know, people are much more stressed. So, you know, and as we are doing more complex cases, calcium cases and so on, so be very careful when we wire, you know, when especially the artery is occluded, you think the wire is in the true proper large branch or lumen, but it can be just in the septal or the side branch. And again, you know, we have type 1, 2, 3 perforations, but just now was type 3. And even rapid, small accumulation of blood can already cause you to have a cardiac tamponade. So one of the risk factors is actually using hydrophilic wires. You can have distal wire perforation. Distal wire perforations hardly seal. So you need to do something. You can put a small coil. Usually my go-to is doing fat embolization. I know some operators from Japan actually do, you know, wide krill sutures. Actually, they've cut down the sutures and so on, which can occlude. Oversized, so another one is using oversized balloons. Calcified lesions, arthrectomy, and so on. So these are the risk factors. So the most important thing is balloon inflation at the site of perforation. Prolonged inflation is necessary. And then you might need to, of course, do, you know, bedside. If you do quick enough, you'll be surprised. Sometimes you don't even have much of pericardial effusion or tamponade. So echo is very important. Reversal of anticoagulation for me is last resort, you know. When I'm already ending the procedure or something like that, I'll do that. No means you'll end up with stent thrombosis, but which in that case they did not give. So there are many ways to approach coronary perforation. So you must always have your covered stent nearby, how to use, and don't have one covered stent, yeah? So sometimes you might need more than one. You might need 2 covered stents. You cannot, especially in a calcified lesion and so on. Be familiar with coil embolization. Not all coils can go down a microcatheter like fine cross. You need a larger microcatheter in your cath lab. And the last ones we hardly do, yeah. So thank you.
Thank you very much. Thank you very much. 1, 2, 3.
Oh, so that's something new, because last time I know in Japan they have the perfusion balloon, but I'm not sure what is what. So how does it work, Kwan?
So it's an RX balloon catheter with rings sequence.
The mic is come. My microphone is not working anymore.
So the ringer balloon is an RX catheter with rings on it that are sequential. So if you were to perforate, you don't have to do the ping pong technique. You just ride your ringer device up to the thing. It's 20 millimeters in length. It comes in 2.5, 3.0, 3.5, 4.0. You inflate it, and all the rings pop up. So basically, it allows for continuous perfusion downstream without sealing the thing. Then you get a second wire. You wire through the rings to the other side, and then you put your covered stent. It has to be a papyrus, because it's true 6 French. And then when you are ready, you quickly deflate the ringer, so the rings will come down, but it doesn't collapse because it's weird, right? It's a ring. It becomes soft, then you slide it back, and then you inflate your covered stent. So you don't have to use ping pong technique.
This is a little bit a different story here, because I think it's always easy to comment after for the case, so don't take it wrongly. But I think this is more like a kind of almost type 5 perforation because it's in the septal. So I would have probably avoided, it can probably be coiled rather than do prolonged inflation. That you avoid, you know, the undersizing or the opening up of the covered stent, of course,
Yeah, I think the reason we provide proximally is for the operator to think what's going on, what to do, so just to do that. But like what Professor Eric Eckhardt mentioned, different perforations are different. If you have a side branch perforation, distal wire perforation, So coil embolization, fat embolization, if you can do it quickly. The other one is your coils. But the first one I showed, actually somebody tried to use a coil, and guess what? The coil actually went backwards into the main branch. So that was another issue, but I didn't show you. It will take more than 15 minutes to show you.
But of course, you have to go far distal enough, and of course, it's better to use like a pro-grid catheter that takes a 0.21 lumen, because if your 0.14 coils may sticky into the catheter. Another alternative is, I always say that this thing, the microvascular plug from Medtronic, it's a very small inverse parachute that goes into 0.14 microcatheter, so that's an alternative to use.
Yes, talking about the very nice lecture, and so talking about the slow flow. So you mentioned the aspiration catheter to deliver the drug in the distal part. It's very important. So using microcatheter, as you mentioned, over 0.14, and also the aspiration catheter is very effective. But so our right coronary, it's okay. But if the slow flow, no flow happened already at that time, if we give the drugs or contrast distal part strongly from the aspiration catheter. At times, sometimes thrombosis move to the circumflex, and circumflex slow flow is totally very serious situation. So that we should be careful of the bifurcation. So especially left coronary, right coronary is okay. Left coronary, we should be careful using aspiration catheter. Slowly injection is okay, but strongly inject at that time thrombus move to the different way. It's okay.
Thank you very much. You're right.
Yeah.
So I think the best way to do with the complication is how to prevent it. So on your case, I think now we have the intravascular imaging. So for the slow flow, nose flow, we can use IVR to see what happened. If we don't see any thrombus, but we see a long attenuated plaque or something like that, we can put a distal protection device to prevent the distal no flow after stenting. Even with the after crossing the lesion, I think the intravascular IVR is okay. We check the vessel size, is it in the side brain, the membranes, and we can prevent the rupture of the vessel. So I think the error of the intravascular imaging is right high. So we can use the IVRs or something like that to prevent it.
Just to add to that, now we have the rapid IVRs, the Avigo Plus, I have in my lab. So you got 4 times pullback, which I find optimal, 8 times. You also got the true vision from China, which can go 10 millimeter pullback. So sometimes we worry about ischemia and recap quickly, and the images are pretty good.
Thank you very much for the lecture. I think for the reason of time we have to go on. And just to remind you that no refill can be a very frustrating thing because it appears, it disappears. We don't always control it. So the next lecturer is Jack. You know that, Jack? It's your turn. I think this is your topic, your favorite topic, huh? The HBR patients. You know this by heart, huh?
Thanks. Thanks. First, I'd like to thank the organizing friends. Good job. Everyone here works too hard, so just relax on a Sunday. I want to talk about balancing between ischemic and bleeding risk post ACS. Just go to the next slide. So these are some of my disclosures. I'd like to talk about, is there really a real balance post-ACS? We always talk about balance, but is it true? Does bleeding really matter conceptually? What are we trying to achieve post-ACS? Defining the real HBR patient and the real HBR type of stents, the risk scores, are they useful at all? What's the confusion in the data, and some of my own thoughts and conclusion. So I like this analogy a lot. We are always traveling between Gibilis and Celia. This is an old Greek mythology. All the Greek heroes have to travel between a narrow strait. To escape the whirlpool, confirmed death, you had to go close to the cliff where there's a 6-headed horrible monster that anyone can bite you. So in order to go and get past this journey, you have to be avoiding ischemic risk and bleeding risk. Why I like this analogy is because it's very clear-cut. Ischemic risk, AMI, stent thrombosis, you die. But bleeding risk is like the usual suspect. It's usually the least suspicious suspect will come and bite you, and you can't predict which one is it as you maneuver very close to the cliff of cilia. You always see this slide, always try to balance between ischemic risk, thrombosis, and bleeding. But actually, I think this is the wrong concept. It's not about the balance. It's about deciding where the patient lies. Is it ischemic or is it bleeding risk predominant? So, for example, Odysseus, Jason was advised to pass by cilia always, closer to the six-headed monster and lose only a few sailors, rather than risk the loss of his entire ship to the whirlpool or turbulence, especially in the post-ACS environment. So does bleeding really matter? Bleeding matters. In this very well-known study, the one-year mortality outcome, if you suffer a major bleed or ischemic event, is close to 30%. You die at 1 year if you have major bleeding or an ischemic recurrent event post-ACS, equally bad. But what is less well-known in the post-ACS environment is that there are so many multi-pronged targets now, so many agents. It's actually surprising that our patients don't bleed anymore with use of antithrombotic, antiplatelet agents. And the determinants for antithrombotic management in coronary artery disease, how hard you drive the antithrombotic management, is determined by the clinical presentation of ACS. When you start thinking of shortening or de-escalating antithrombotic, it's always the demographic and comorbidity. So when we talk about balance, it's talk about deciding between left or right, not actually trying to balance it. We all know that the risk factor associated with increased bleeding and the risk factor of ischemic event somehow mix, but again, the most important presentation is actually ACS. And actually, the clinical angiographic subtype, putting stents in, if you manage it quite well, is less and less of an important factor determining ischemic coronary events, even in the ACS subset. So the ACS presentation is the crux of it. In the previous presentation, I mentioned STOP-DAT 2 ACS. What did we learn from the STOP-DAT 2 ACS? In the ACS cohort, shortening a DAPT regime with clopidogrel-based management to just 1 or 2 months failed to meet the superiority outcome of shortened DAP. So you still need 12 months of DAPT if you're using aspirin clopidogrel for ACS subset. What do we learn from STOP-DAT 3 then? An aspirin-free strategy, even if you use a third-generation tirapyridine like prasugrel, also failed to attest to superior bleeding risk reduction within 1 month and with an associated higher coronary event rate. So DAPT with aspirin-free shortened therapy is not advisable and still remain a gold standard to combine both in 1 month after a PCI. And then this slide is also key. We often say that major bleeding, major ischemia is similar post-ACS, but the frequency, if you overlap both, ischemic events is far more common post-ACS compared to bleeding event, no matter how you look at it. It's just we're always very scared of bleeding, so sometimes we overemphasize bleeding risk and truncate unnecessary most of the time. But I will show you the flip side. ARC HBR criteria, everyone's very familiar. I will just like to point out again and again this fact. HBR definition in the ARC consensus needs to achieve BUC3 or 5 prevalence of bleeding more than 4%, or risk of intracranial hemorrhage more than 1% within 12 months after a PCI. So it includes 1 major and 2 minor, but if it's just 2 minor criteria, it's not equivalent to 1 major. If you are just 2 minor, we say it's equivalent. Like Hui's case, they say 2 minor equivalent yesterday in the live case. Actually, it's less than 4% and less than 1% ischemic. So let's say you have an elderly patient, 75 years old, mild CKD, 2 minor, they are not equivalent. They are not true high bleeding risk. You know all the factors for HBR major and minor, but they are not equivalent risk. Our Japanese colleague, Professor Nakamura, used the same ARC bleeding risk criteria in the Pendulum Registry, 6,400 patients in the Asian cohort, predominantly Japanese, and he found that actually the ARC HBR bleeding risk criteria reclassified a lot of patients, or half of our East Asian cohort patients, into high bleeding risk. But if you further look at it in our Asian cohort, what actually reaches 4%, BUC3 and 5, more than 1% intracranial bleed, besides ARC HBR consistent, which is severe CKD, anticoagulant use, severe anemia, low platelet count, prior ICH, malignancy liver, cirrhosis, end stage of steroid use, prior GI bleed. You also have heart failure. You also have low body weight. You also have history of peripheral arterial disease, transfemoral use. If you look at ACS, ACS by itself is not HBR. ACS is 3%, no more, not more than 4%. So by itself, ACS is not a high bleeding risk subset. Okay, so if you look at some of the validation studies, I won't go too much into that. I'm going to just skip into it. But just to say that if you look at the HBR criteria in our Asian subset, all of us know that 1 in 2 of our PCI patients in the ACS subset is HBR. If they are not HBR now, they'll be HR tomorrow. So whenever we intervene on our Asian cohort, we need to know that predominantly they're going to be more elderly, low body weight, female. A lot of times this elderly patient also had atrial fibrillation, prior stroke, peripheral arterial disease, so they are true HBR. And therefore, in this HBR definition, we know that the risk of major bleeding is also double up every time the HBR criteria is repeated. For example, if you have HBR1 major, you pile on HBR1 major plus 2 minor, the additive risk of high bleeding risk keep piling up synergistically. And a lot of patients have double major, or minor criteria combined, and it keeps going up. So it is a useful tool, but there's a tendency in the Asian cohort to under-predict major bleeding risk, and its predictive ability may be optimized by doubling up the number of times the criteria is met. So all DES stands the same for shortened depth. The essential elements of a DES beneficial HBR patients, I'm going to go through some of the first results. The first RCT was the Leaders 3. You're all quite familiar with this trial. They have high mobility, and this really fulfilled high bleeding risk criteria, even though the early studies. Because of that, whether you put a bare metal stent or you put a drug-eluting stent, the risk of major BUC 3 and 5 bleeding is 7.2%. And this was actually the highest HBR trial that was ever done in terms of bleeding risk percentage. The other one that met the HBR criteria of above 4% was an Onyx 1 study. It was between Onyx 4.9 and the Biofreedom stent of 4.4. All the other HBR trials, they are non-randomized, single-arm enzymes, 2.2%. Bioflow DAPT, actually 1 month randomized control, but it was close to 4%, but not quite 4%, 3.5%. Senior trial, which is again reinforced the fact that just age alone is minor criteria, less than 4%, 3%. Evolve short depth, again 2.9%, again single-arm non-randomized trial. Master depth was not truly trying to evaluate HBR, it's just between short and long depth, again 2.3%. So it's not validating that you can shorten depth. Why is this the case? If you look at the criteria for recruitment, you have to actually have all the inclusion criteria before you come close to 4% HBR risk of PUC 3 and 5. Bioflow adapt also have all the recruitment criteria, and therefore its risk is 2.5% as high. Close to, but not quite 4%. So inclusion criteria for HBR patients vary between clinical trials, and therefore they don't make the mark. So again, to just re-emphasize the data, bleeding risk, ischemic risk, equally important, but at 1 year, if you do meet HBR major criteria, you qualify as a high bleeding risk, your bleeding risk will then trump ischemic risk at 1 year. But if you do not have HBR risk criteria, then your ischemic risk far outweighs your bleeding risk. And if you undertreat ischemic risk, the patient do not benefit post-ACS. Our Hong Kong colleague also showed in their meta-analysis in their own data, if you have a major bleed post-PCI, up to 5 years, your event rate is very high and increases death. So what does the guideline tell us? The guideline tells us that you can actually drop DAPT after a month, but they only endorse 2 stents, which is the Zetteromer stents and the Biofreedom stent, because those are the data-driven HBR stents. And the guidelines in 2023 for HBR patients, they reinforce 2 strategies. Strategy 1 is abbreviated DAPT. You start with whatever DAPT you want, whether potent, non-potent, but you shorten the duration to a month, and preferably 3 months, depending on bleeding and ischemic risk. Or you do de-escalation, where you start out with a potent, and you rapidly de-escalate to a less potent agent, and drag it out to 3 to 6 months before dropping it. So between shortening and de-escalation, I think most of us do a combination of both. So in the ESC guideline, again, in the patients who have OAC, they say that the default strategy is to have a triple therapy in a stable cohort up to just a week. But in the ACS cohort with high ischemic risk, try to drag it out to at least a month. Then you shorten it to dual therapy with NOAC, and after a year, both consistently, just NOAC alone. So again, ESC guidelines suggest in patients with oral anticoagulation, PCI is performed without interruption of the VKA or NOAC, and try not to breach anyone. Means you don't go and give Klaxane on the side. Just give rapid onset, on-off NOAC preferably. But in patients who are on Coumadin, you do not want to administer any more heparin if the INR is already above 2.5 when performing the PCI. In patients with NOAC, regardless of the timing of the last administration of NOAC, low-dose anticoagulation can be given. These are some of the bleeding risk strategy you can consider pre-PCI, during PCI, post-PCI. Important is to risk stratify them. Important is IVUS intravascular imaging, optimal stent selection, deployment, and the strategy of either shortening or de-escalating that. There's some data supporting the use of routine PPI to protect GI bleed post-PCI with that. In the APSC consensus that we published in 2020 on the recommendation, we recommend more a binary approach. We use the ABO algorithm to prime people to yes or no, high bleeding risk. A, frail elderly more than 75, but with asterisk. Asterisk meaning you must combine with a second criteria. All advanced age above 85, life expectancy less than a year, combined with spontaneous intracranial bleed under B, recurrent GI bleed, hemoglobin less than 9, not 11. Organ failure, either liver cirrhosis, end-stage renal disease requiring dialysis, bone marrow failure or platelet count of less than 50,000 or stroke in the last 6 months. And we risk stratify the high-risk ischemic risk using a CVD algorithm. C for prior coronary event, high-risk coronary anatomy, documented multivessel disease. V for established peripheral arterial disease, cerebral vascular event or disease. D for diabetes on treatment, eGFR less than 60, micro or macro albuminuria, and heart failure due to coronary artery disease. And this is a very simple flow chart. We don't advise you when post-ACS or not. If you need to transit from a DEP and you think that you need to transit them to CCS, assess then the CVD first, meaning ischemic risk first. Ischemic risk low, try not to prolong the DAPT, you just go to SAPT. Ischemic risk is high, then look at whether it's acceptable bleeding risk or not acceptable bleeding risk. If it's unacceptable, SAPT. Acceptable, consider DAPT or dual pathway inhibition. And this is a follow-up publication where we endorse the 12-light regime. After 3 months, in the low bleeding risk subset, go to ticagrelor monotherapy. In Asia, for patients on OAC, we endorse routinely 1 month, not shortening, because the practice pattern in Asia, not a lot of intravascular use, so we're a bit worried about saying you can shorten and drop aspirin within 1 week post-PCI. So personalization is key, and I would like to conclude that major bleeding is highly correlated with mortality, especially post-ACS. The real-world data of HBR patient in Asia is at least half of our patients. Proven DES for HBR patients with short DEP, there are only 2. DEP strategy of HBR patient include the fact, I want to emphasize, bleeding risk or trump ischemic risk if they score positive. We need to shorten the DAPT duration or de-escalate the type of DAPT. So again, when you look at bleeding risk, you look at ischemic risk, they look somewhat overlap. There is a small overlap subset. But bleeding factors and ischemic factors both give rise to death, but the incidence of it is not the same. So bleeding risk is not equivalent to high ischemic risk, but both are bad and both kills our patient. However, the optimal duration and intensity of death for patients with high bleeding risk is not known, but I advise you if they score high on high bleeding risk, it would trump ischemic risk, and you do need to have a strategy to shorten the death in the subgroup. So in terms of usual suspects, we need to maneuver around cilia, try to avoid the bleeding. It doesn't happen as often as you think, but don't undertreat the ischemic risk. Thank you very much.
Thank you, Jack, for an excellent lecture. So we, because of time, so I think we have maybe one or two quick questions.
You know, we discussing the lectures every time. So the last 50 minutes we can squid them. So we have some time for discussion, Jack, if you want. But Jack is going.
So
okay, you introduce the last speaker.
Yeah, so the last speaker of this session will be Dr. Wei Chun Huang from Taiwan. And he is going to talk about cardiogenic shock, state of art. Okay, Dr. Huang.
Thank you, Dr. Wei and Eric. And ladies and gentlemen, it's my honor to be here to present this topic to you. I have nothing to disclosure. As we know, AMI cardiogenic shock, the STEMI, around 5 to 10% of STEMI, the mortality up to 60%. We show a case, 53 years old male with smoking history and also chest tightness for 5 to 6 hours. So for EKG, we can see there's a ST elevation in one end AVL. So the X-ray shows pulmonary congestion. So we check the blood pressure is around 90, and after use of ventilator, the BP dropped to 83, even under IV norepinephrine. So we transfer the patient to cath lab. So from the cath lab, we can see the RCA. There's a disc region in the middle part. But how about lemon? So we cannot see circumference or LAD. And for the patient suffer from ventral arrhythmia immediately. So we perform more than 20 times TC shock. We almost smell the barbecue. And we activate the heart team and arrange the ECMO and the CPR can perform together. So we can see our staff do the CPR and that the cardiac surgeon perform the cannulation. So we perform the artery sheath cannulation smoothly, but unfortunately we cannot advance vein sheath. So we have to move the patient to the table. First, we mentioned about the hemodynamic support. As we know, there's a different method to support the patient in AMI with cardiogenic shock, including the medication, IBP, tandem heart ECMO, and the impeller. And as we know, IBP we have to use in patient with stable reason, and also the tandem heart ECMO and the impeller can provide the oxygen continuous. And also IBP is a counter pulsation, and tandem heart and V ECMO is central fusion flow. But impeller is axial flow, so now we favor use impeller. But in Taiwan, the impeller cost about 40,000 American dollars. They have paid by themselves. So how about IBP in the patient? So from shock study, we can see the shock 1 study show if PCI is successful, the mortality only 39%. If unsuccessful PCI, the mortality up to 85%. And shock 2 study compared with the IBP and the non-IBP, actually there's a 30 days mortality. There's no difference between two groups. So the guideline suggestion routine use IBP is not recommended. It's a 3B indication. So how about the ECMO? In Taiwan, the ECMO is more popular because the ECMO is our insurance investment for the ECMO. So ECMO can provide up to 8 liter per minute output for the patient. So ECMO, the advantage of ECMO is that they decompress the venous system, increase coronary, cerebral, and the peripheral perfusion, and also provide the blood oxygenation. However, it will increase the LV afterload. So there's a study use a systemic review and the meta-analysis show use of ECMO compared with ECMO compared with no ECMO. Actually, ECMO has better result, 30 days survival. And so from this observation trial, we can see the VA ECMO actually better survival than control, and also provide superior circulation support. And the meta-analysis of cardiac shock post ACS, we can show the VA ECMO compared with IBP have more 30% higher 30 days survival. However, the guideline show no randomized treatment allocation, important limitation. So how about when we put the ECMO, the LV unloading? LV unloading, so we can see when we use ECMO, if we increase the flow, we increase the LV pressure and decrease the LV volume. So if we use a different kind of method, we can reduce the LV pressure. So actually, there's many methods to reduce the do the LV unload, including the lava ECMO, IBP, or the impeller, or different kind of device. So for this study, if we use IBP, this meta-analysis, LV support, and also a lava ECMO, we can see the LV unload is better, had better result than LV without LV unload. So there's a study compared with the IBP with ECMO, and compare with ECMO only. Actually, IBP with ECMO with LV unload is has better result. And have better 30-day survival. This study used ECMO. They use impeller with ECMO do the LV unload. So LV unload has better 30 days mortality. How about ECPR for this patient? In Taiwan, we have many studies show the ECPR result. So this is we collect the in-car patient for more than 135 patients. You can see for ECPR, HS can have a extend the duration of CPR time. Usually CPR time about 35 minutes, but for ECPR with average ECPR time about 55 minutes, and successful winning about 85%, survival to discharge about 34%. Compared with conventional CPR, only 10%. Actually, the ECPR is better than conventional CPR. So analysis, this study analyzes the in-car and all-car survival rate, and we can see if we can activate the ECMO team quickly, so survival will be better than delayed ECMO. And this is another study show actually survival in car or all-car patient is about 33% if duration of ischemia less than 75 minutes. And this is a Taiwan group study, collect the 3-year prospective observation study in car patient more than 10 minutes and focus on cardiac origin. So we calculate the result. We can see follow-up about 1 year. We can see the eCPR patient has better result compared with the conventional CPR. And this is another Korean study respected. They also show the eCPR result has better result than conventional CPR. And this is a study from Berlin for Germany, and they do the eCPR for refractory all-car patient. And for the result, we can see the door to ECMO time less than 30 minutes has better result than door to ECMO time less than more than 30 minutes. And survival rate can increase about 39%. And another study show meta-analysis study show the conventional eCPR and also eCPR. We can see the eCPR has a better result compared with the conventional CPR. Well, we return to the case. We have to continue to the CPR for the patient and also perform the ECMO. Because the vein, because the wire is too soft, so we cannot advance the venous sheath. So we have to change the super stiff wire, and finally we can smooth deliver the vein sheath. Finally, when we set up the ECMO, although we activate the ECMO team very quickly, but because the device problem, in total we CPR the patient for about 1 hour. We decide to do the PCR instead of the cabbage. So we use a soft wire to pass the lesion, and after that we use a thrombectomy to remove the part of thrombus. So we can see there's a very narrow lesion in LAD element distal part. So finally we can see the two lumens. So we use 2 wire and open up the lesion, and we decide to perform the circumflex lesion first, and later on, after the circumflex stenting, so we decide to the stenting to element to LAD. So we also did the OCT for the patient to make sure that we put the right size of the stenting. So this is another PDCA for the patient. So finally we're stenting from lemon to LAD part. Only single stent for treat this patient because we see there's no significant lesion in LAD in circumflex orifice. So we also did the OCT after the lemon stenting. But because the male position of the lemon orifice, so we did another port for the patient lemon. So finally we get the chemistry flow for the lemon and also circumflex. But you can see, I'm not sure it's a vasospasm in the circumflex or proximal part or not. But we decide to complete the procedure. The patient still ventricular fibrillation. So in our hospital recently, we set up the smart care in cardiogenic shock. We set up the cardiogenic score from we collect data for 10 years, and we collect the data from the admission. Use a different category to collect data. We set up the patient into 5 strata. So if our score more than 25 has very high risk of mortality, and very low has less than 70% mortality. So the AUC curve around 0.0887, and also compared with the 30-day mortality has a powerful long-term the prediction. And also we use artificial intelligence care with cooperation with university to use a random forest and variable importance to set up another AI model in our hospital. And with the shaped expansion to see what is the reason to induce the cardiogenic shock, the poor outcome, so we can improve the poor outcome. So in our hospital hospital information system, we have an AI critical care button. If you click the button, you can see the cardiogenic shock risk for this patient about 55%. And also we can check other category, use our AI system. So we also use a system to use in other hospital. Our result actually have a similar result with other hospital. So further confirm our result, AI result in the accuracy in different hospital. So the patient actually after open up the lesion, so we decide to do another cardioversion. Luckily, the patient returned to normal sinus reason. So we performed the hemodialysis for the patient, but because the severe heart failure, in about 1 month, we have to do the tracheostomy for the patient. And also, we can see the LV EF is not so good. So we follow the patient about 3 years later, so we can see the RCA still has discouraging in the middle part. So layman has a very good result for the patient. The patient can return without tracheostomy and back to work. And in conclusion, the present evidence show routine IBP is not the suggestion. IBP can select in select case, especially in the ischemia patient. And also ECMO is helpful in AMI cardiogenic shock and improve survival. Always consider the LV unloading, and the eCPR outcome actually better than conventional CPR. And welcome to Taiwan next year, April 12 and 13. Thanks for your attention.
Thank you very much, Professor Huang, for this very nice overview. Quite impressive management of this patient and good outcomes. I'm informed by Hui that we cannot have a discussion, so we really thank you for
thank you
for being here, and I would like to thank in name of all the panelists for your presence here. We learned about plaque erosion, calcium management in STEMI, PCI complications, HBR patients, cardiogenic shock, and all this in 1 hour and 15 minutes. That's a great job. Thank you for all the speakers for preparing your lecture. We know it's not always an easy job. And we invite you to the Abbott Satellite Symposium that will start in a short moment. Thank you very much.